So the patient may develop liver cirrhosis. So for this patient, what is cirrhosis? So cirrhosis is an end-stage condition. It involves chronic liver disease, and it is as a result of the gradual destruction of liver tissue, which leads to scarring and increased scarring. And this would impair liver function and can lead to liver failure. And might be caused by alcohol abuse, might be caused by hepatitis infection, might be caused by chronic hepatitis. Drug might also be drug induced, inherited, or because of mild bile duct blockages. Initial disease presents is usually just mild, asymptomatic with a bit of weakness, anorexia, and weight loss. Later, the patient would have declined liver functions, resulting in anemia, impaired clotting, increased susceptibility to infection, jaundice, fat malabsorption. Eventually, advanced disease would also present with kidney and lung dysfunction, altered enzymes, altered bilirubin levels, lower albumin levels, and also elevated blood and ammonia levels. So the consequences are that the patient might develop portal hypertension, they might have collateral and gastroesophageal varices where the collateral circulation, smaller blood vessels enlarge and then allow for an alternative pathway for blood because the GI tract is in the blood flow in the GI tract near the abdominal wall. As a result, varices form and become enlarged and engorged with blood. Now, these varices can result to massive bleeding, and sometimes this bleeding is fatal. Again, the patient might have ascites, where this is an accumulation of fluid in the abdominal cavity. It indicates that there is very high liver damage, and it is also thought to be a consequence of portal hypertension, reduced albumin synthesis, also altered kidney functions. And also a patient with cirrhosis might develop hepatic encephalopathy, which now is just abdominal neurological functioning. So this areas can now bring about changes in personality, mental health abilities. Patient is unable to concentrate. Sometimes they're unable to, they are not oriented in time, place, and person. They also might have amnesia, seizures, and might get into a coma, and this may also lead to death. This is usually as a result of now elevated blood ammonia levels, and these ammonia levels now pass the blood-brain barrier. Just showing us what would happen to a patient who is still cirrhosis, who has liver cirrhosis. In liver cirrhosis especially, malnutrition is extremely common. In 50 to 100% of the patients with decompensated liver disease, you expect to have all those to have malnutrition, and you expect about 20 to 30% of patients with compensated liver disease cirrhosis to have malnutrition. And progression of malnutrition is associated with the progression of liver failure. This is a problem because malnutrition is associated with a higher rate of infection, complications, hepatic encephalopathy, and ascites, and also associated with the independent predictors of lower survival in cirrhosis, especially for patients with sarcopenia, which is the reduction in muscle mass and function due to aging or disease. So this simply is just showing us how malnutrition what would cause malnutrition in a patient with liver disease. So malnutrition in this patient may be cirrhosis related as a result of dysfunction, fluid retention, cognitive dysfunction, so they're not able to feed themselves, hyperammonia because of the elevated blood ammonia levels, anabolic resistance, and now the cause of the liver disease. And then we have system inflammation, metabolic dysregulation, visceral fat accumulation, insulin resistance. Might also be as a result of physical inactivity due to muscle disuse and cardiovascular deconditioning. And also there are those environmental factors that may aggravate malnutrition in this patient. So the social determinants of health, late diagnosis due to lack of assessment, confusion. Sometimes you also even have confusion regarding management responsibility. And in healthcare settings, even things like just late feeding might aggravate the metabolism of the patients and make them further susceptible to issues of malnutrition and especially sarcopenia. This then would be manifested as frailty or now as sarcopenia. Now the outcomes would be further decompensation, increased healthcare utilization, decreased quality of life, and sometimes death. And if it is a patient who is going to undergo a transplant, this patient might be at risk for adverse post-transplant outcomes. So what are the consequences of cirrhosis related to nutrition? When we're looking at the carbohydrates, remember there's decreased skeletal, muscle, and hepatic glycogen production. Remember, one of the things that our liver does is to synthesize and break down proteins and amino acids. There's also increased catabolism, increased use of branching amino acids, now increased lipolipids, and then you want the percentage of the total energy from fats and carbohydrates and protein that is used in non-cirrhotic patients after 36 hours is the same as is used in a patient with cirrhosis over 12 hours, because they're not able to, their storage abilities are impaired. So this was seen especially when an overnight fast pattern was studied in healthy people versus patients with cirrhosis. So how do we identify if a patient is malnourished? So look at these patients. So who is malnourished? Is it the patient with high BMI? Is it the patient with normal BMI? Is it the patient with low BMI? Let us remember, malnutrition is a state of nutrition in which a deficiency of energy and or other nutrients causes adverse measurable effects on tissue or body in form of composition, function, or clinical outcomes. So when we're thinking about malnutrition, it is not just about you cannot look at just the weight. You're looking at other parameters that would other parameters that would indicate malnutrition. So what do we look at? One of the things we look at is we perform as dietitians in the hospital a rapid nutrition screen in all patients and complete a detailed assessment for those who are at risk for malnutrition. Any patient who has a BMI of less than 18.5 kilograms per meter squared has a very high risk for malnutrition. Patients with, also, if you're diagnosing obesity, you need to look at confounding effect of the confounding effect of fluid retention, and always include an assessment of sarcopenia. We also assess muscle mass. Sometimes in the hospital, we do what we call a nutrition-focused physical exam, where you're able to assess the muscle and fat and micronutrient status of a patient. So it is also, we also can use the BIA, the bioelectric impedance, and which is a good alternative. Also, again, just simple anthropometry. In the clinical setting, you can also assess muscle function, and we also assess dietary intake. Assessment of the diet should ideally include the quality and the quantity of food, if the patient is on any supplements, if the patient has sodium in the diet, the number of meals they usually have during the day, and if they experience any barriers for eating. This just shows us this is a good algorithm to have to remember. So in case we're looking at an adult, a child, we'd look at the child PAS score. If you're looking at an adult, anyone with a BMI of less than 18.5 is high risk. Also assess, if this high risk patient, assess for sarcopenia, assess detailed nutrition assessment. Also for the patients with medium risk, do the same thing. Assess for sarcopenia, assess for detailed nutrition, detailed nutrition. So in case there is fluid retention in a patient, body weight should be corrected by evaluating the patient's dry weight post the acetic tap, or body weight that is recorded before the fluid retention, if that weight is available. If in case these weights are not available, then you need to subtract the percentage weight of the patient based upon severity of the ascites. So if the ascites is mild, subtract about 5% of their total weight. If it is moderate, subtract 10%. If it's severe, subtract 15%. If the patient has bilateral pedal edema as well, you subtract an additional 5%. In patients with cirrhosis, you have to have aims in primary, secondary, and tertiary prevention of malnutrition, and this further prevents the occurrence of undesirable outcomes. So in primary prevention, our aim is to prevent the development of malnutrition and or to delay onset. Do your malnutrition screening, assess for muscle dysfunction. And if in case the patient is not malnourished, and continue to educate the patient and the caregivers and encourage positive health behaviors. If you're working with a patient, now we're doing secondary prevention, early diagnosis is key. You need to initiate prompt treatment of malnutrition, and you need to slow progression of malnutrition. Again, assess by evaluate the first initial assessments, of course, the malnutrition screening and screening assessment for muscle dysfunction, evaluate for etiologic risk factors, and explore dietary preferences and barriers to both diet and exercise. Then furthermore, if your goal in tertiary prevention is to rehabilitate and reverse malnutrition, keep reassessing for progression of malnutrition, frailty, or sarcopenia, despite the primary and secondary efforts. Again, if you are working in a healthcare setting, this patient should be referred to a dietitian, to the physical therapist, to a health and behavioral specialist for management, especially if the patient has behavioral issues that may exacerbate malnutrition. So this is just the management. We've talked about diagnosis. We need to talk about management, where the management should be liver, you manage the disease, etiology, manage ascites, talk about physical activity, and increase calorie intake, calorie and protein intake. So in case you have this patient who is with liver cirrhosis, start nutrition counseling with a multidisciplinary team to support the patient. Ensure that the patient is having adequate intake of protein and calories. Optimal daily energy intake should not be lower than 35 kilocalories per kg actual body weight. This, if the patient is extremely malnourished or is very frail, this recommendation can go as high as 40 kilocalories per kg body weight. In terms of protein, minimum protein intake should not be lower than 1.5 grams per kg body weight. This is a high protein diet. And again, in cases where the patient has sarcopenia, in cases where the patient has ascites, this recommendation can go as high as 2 to 3 grams of protein per kilogram body weight. If in case the patient intake is cannot be able to achieve these targets, we might include late evening or breakfast that contains nutritional supplementations, especially in patients who have decompensated cirrhosis. Again, we want this patient to have supplements that have branching amino acids. Remember, these are branch chain. The branching amino acids are liver sparing and are metabolized more in the muscle than in the liver. So these branching amino acids include leucine, isoleucine, and valine. In patients with malnutrition who are unable to achieve adequate dietary intake, even with the oral diet and oral supplementation, we might recommend a period of enteral nutrition support. So the patient might get an NG tube placed so that they can achieve their dietary goals. If in case the patient is obese, because we'll have a patient with liver cirrhosis, remember, but then they're obese. It is important to encourage mobility where they are able to move, and implement nutrition and lifestyle programs to achieve progressive weight loss. You want to encourage them to lose between 5 and 10% of their total body weight, especially if their BMI is greater than 30 kilograms per meter square when corrected for water retention. In some cases, we might adopt a hypocaloric diet, sometimes reducing the diet by reduce the total calorie intake by about 500 to 800 kilocalories per day, and include an adequate amount of protein. Remember, the protein recommendations do not change. At minimum, 1.5 grams of protein per kg per day to achieve weight loss without compromising protein stores. If in case the patient has a hepatic encephalopathy, avoid protein restriction. Optimal daily protein and energy intake should not be lower than what we have discussed for the patient with cirrhosis. We also encourage the consumption of vegetables and dairy, consider BCAA supplementation. In patients who can tolerate oral intake is always preferred. But then those who are in grade 3 or grade 4 encephalopathy and are unable to eat, we may consider placing a nasogastric tube in patients with protected airways, or we may also consider parenteral nutrition, either partial parenteral nutrition or total parenteral nutrition, depending on the duration. What are the micronutrient recommendations? So we need to we do not, and we should not, as healthcare workers, give supplements or micronutrient supplementation without confirmation of diagnosis, so that we can avoid toxicity, especially in these patients. So administer micronutrients and vitamins to treat confirmed or clinically suspected deficiencies. So if you're able to, a patient with HALA, you're able to see a patient who's has hair loss, you can clinically identify a deficiency, and this can then be confirmed through blood tests. We also assess vitamin D levels, especially because in cirrhotic patients, deficiency is very prevalent. And in case there's deficiency, you want to supplement the vitamin D. We also want to evaluate bone mass density in patients with cholestatic liver disease who are on corticosteroid treatment and before liver transplantation. In those patients, if the bone mass is low, then you want to include supplemental calcium, supplemental vitamin D. Finally, on the slide, in cirrhotic patients with ascites, there should be a sodium restriction. We leave the restriction at 2 grams of sodium, which corresponds to about 5 grams of added salt per day. This is according to the EASL guidelines. So the 2 grams of sodium, when we say low sodium versus no sodium, is because especially in these patients, there is a lot of dyscalculia. The taste of the food food doesn't taste good. If you work with patients with liver disease, they will always tell you, I have no appetite, I can't taste the food. So a little bit of salt, that 2 grams per day, is useful to improve palatability. Because if you remove everything, then this patient with already very low appetite will have a lower calorie intake. So in case the patient is going for liver transplant, then nutrition status needs also to be assessed. Preoperatively, again, remember to screen for malnutrition. Treat sarcopenia prior to elective surgery. Before the patient has surgery, please move them back to the situation where we are doing primary prevention. This will allow an improvement in body protein status and also improve their clinical outcomes. Preoperatively, if the goal is maintenance of nutrition status, plan for total energy intake of about 30 kilocalories per kg body weight and per day, and a protein intake of about 1.2 grams per kg. If the goal is improvement of nutrition status, plan a total energy intake of at least 35 kilocalories per kg per day and a protein intake of at least 1.5 grams of protein. Also include branching amino acids. In post-transplant, the patient will be on immunosuppressive drugs. We again would increase risk of infection. So immunosuppressant drugs affect nutrition in certain ways. Number one, there might be gastrointestinal side effects such as nausea, vomiting, diarrhea, pain, mouth sores. There's alteration in appetite and taste perception. There might also be hyperglycemia and diabetes, fluid and electrolyte imbalances, and also issues with hypertension, hyperlipidemia, protein catabolism, and increased osteoporosis risk. After transplantation, the patient has increased energy requirements, especially again due to stress of surgery. And you need to include snacks, you need to include enteral supplements where needed. Again, in case of deficiency, we encourage vitamin and mineral supplementation. For this particular patient, Food safety is a major, major concern. So you cannot, this patient will not have food from outside, food from whenever. We need to know how safe this food is and how it has been prepared. Again, after transplantation, we initiate a normal or enteral tube feeding, preferably within 12 to 24 hours, as soon as possible. If it is not possible or it is impractical, then we prefer parenteral nutrition, especially if the patient is on mechanical ventilation or is in ICU. No feeding will increase complication rates. So feed whatever there is, make sure the patient is fed. After the acute post-operative phase, we need to, again, we go back to our recommendation, at least 35 kilocalories per kg per day and a protein intake of 1.5. And also, of course, continue to follow the ERAS protocols, post-surgery protocols. We consider parenteral nutrition in patients with unprotected airways or patients with hepatic encephalopathy, especially those ones who have cough and swallow reflexes that are compromised. We utilize tube feeding and or parenteral nutrition with a reduced target. If in case the patient is obese, you reduce the target energy intake, but increase the target protein intake so that we may maintain function. We may maintain protein and protein muscle function. If in case the patient is critically ill, we consider the nutrition status and presence of sarcopenia. Supplement dietary intake enterally or parenterally if it is not possible. In nasogastric tubes are not contraindicated in patients with non-bleeding esophageal varices. But in case the varices are bleeding or there is a risk of bleed, then do not put the tube. Further, we want to avoid PEG tube insertion in patients with cirrhosis due to the risk of bleeding. We can take care of energy intake, ensure that you're able to meet the goals. So this is basically the calorie intake should be at least 35 to 40 kcal per kg per day, or at least 1.3 times measured resting energy expenditure. We take care of their daily protein, make sure at least 1.2 to 1.3 grams, and also utilization of use standard regimens, especially in critically ill patients. There is minimal evidence on the more specialized formulas for them. But in case the patient has hepatic encephalopathy as well, consider BCAA enriched solutions, the branching amino acids. Nutrition support may accelerate resolution of hepatic encephalopathy and improve survival rates. In case, then we have looked at the patient with cirrhosis. What about a patient with hepatitis? Just hepatitis. Remember, hepatitis inflammation of the liver can result from viruses, might also result from acute hepatitis as a result of alcohol intake, etc. There are several symptoms: fatigue, nausea, anorexia, pain, liver enlargement, jaundice as well. So when we look at supportive care, bed rest and appropriate diet. We avoid substances that are harmful to the liver. For example, drugs, alcohol, dietary supplements that might also cause liver disease. Nutritionally, the patient may require a high calorie, a high protein diet to replenish stores. where patients are not able to, their intake is impaired, liquid supplements may improve intakes. We also encourage small frequent meals because this makes it easier to tolerate, especially if the patient has gastrointestinal discomfort or anorexia. Where necessary, the patient might also require electrolyte replacement. And we also recommend sodium and fat restriction. If in case the patient that is presenting has gallbladder disorders, this is just a the gallbladder. Maybe as a result of gallstones or any other gallbladder disorders, then you want this particular patient to increase the amount of fiber that they are having slowly over with several weeks. Adding soluble fiber to the diet helps to sequester and bind the bile that is in the stomach. This helps to avoid symptoms of gastritis. If in case this particular patient has reflux, avoid alcohol, avoid caffeinated or carbonated drinks, avoid chocolate, avoid citrus fruits, or anything else that the patient may feel aggravates their reflux. Also encourage this particular patient to eat small frequent meals. In general, you want this particular patient to have a low-fat diet and then just watch for their individual tolerance. If any food that they are having aggravates their symptoms, then they should not be having it. So in all this, what can we conclude? One, it is important to halt progression of fatty liver disease towards cirrhosis and liver damage. Dietary interventions such as micronutrient modification, anti-inflammatory food, and weight loss strategies are important. Medical nutrition therapy is key in management of liver cirrhosis, especially because the burden of liver cirrhosis is high and identifying malnutrition and treating it is key. Remember to assess for sarcopenia as part of your nutrition focus physical exam. Optimize the patient's calorie, protein, and protein intake, considering their various conditions. If the patient is obese, if the patient has hepatic encephalopathy, or if they're already malnourished. Remember, minimum protein intake, especially if the patient is malnourished, is at minimum 1.5 grams of protein per kg per day. Micronutrient supplementation is necessary where needed, is extremely necessary, and sodium restriction, low sodium, not no sodium. And in case nutrient intake is impaired, consider oral nutrition supplementation. Thank you so much for being with us today. And at this juncture, I will take it back to a moderator and we can answer some questions. Thank you so much.
Thank you so much, Christine, for an elaborate and a well thought presentation that we have done today. Having said so, we want to just clarify a few things so that I open so that we can answer some questions that our attendees has just posted. These patients with liver cirrhosis, remember we have said we are not saying limit, but we are lowering the sodium. If it is fat, we are giving minimal. Why? Because of other related deficiencies which comes about when you restrict such nutrients to these patients. For example, fat soluble vitamins. When you restrict fat, and many other things. But I think this is a wake up webinar that will give us insights to go and read more. So maybe we can answer a few questions that our viewers and our attendees have just posted. From anonymous attendee says that are these webinars available in
There is a question on, an anonymous attender is asking whether that they were diagnosed with fatty liver disease and were advised to control diet. How do they know that they are okay? It is important. One of the things that we mentioned is that you need to go through follow-up. Long-term follow-up is key, so please follow up with your primary healthcare provider. The other question is, how do you modify diet for a HCC, end-stage liver disease patient with recurrent hypoglycemia? So if a patient has recurrent, one of the things that we really encourage is very small, frequent meals. So increase meal frequency. Instead of having the patient feeding every 3 hours, if they're currently doing every 3 hours, you can do every 1.5 hours. And at each stage of liver disease, remember, it depends on how the patient is presenting. If the patient is sarcopenic, if the patient is it depends. The amount of protein depends on the patient condition. If the patient has sarcopenia, if the patient has low albumin, so start at 1.5, and then with the support of your dietitian, then where necessary, increase the amount gradually up to you can go up to 2 to 3 grams of protein per day.
I think we don't have any other questions.
Well, if I can chip in, there's a question from Victor, and he's asking about what's the period for the recommended weight loss on 5% body weight? Well, if I can just take it up and answer that. And if you look at weight loss, there's a range of the amount of weight loss is also varied depending with the individuals, because you have to consider all the other factors in terms of the body composition of the patient, what is their age, the gender, the amount of body fat they have, vis-a-vis the muscle mass that you want, that you're initially starting with. Together, as you already know, also the hormones also play a big role when it comes to weight loss. So the recommended is the 5% is recommended is within a month, or at least a month, not less than a month. Because remember also, losing weight, a lot of weight too rapidly, you end up also getting muscle loss, having nutrient deficiencies and other health issues. And also these sudden drastic changes to the diet and the exercise may not be sustainable in the long run. So you have to be careful when it comes to the issues to matters to do with weight loss. Thank you.
We also have a different anonymous attender who is asking, who is talking about their gallstones. It is important that you have an individualized plan with your dietitian, where possible and when it is very necessary. See your dietitian and they would be able to give a more individualized plan for you.
From Helen Mreidi is asking, kindly give examples of branched-chain amino acids.
Thank you so much for the question. As it was mentioned earlier, we have leucine, isoleucine, and valine. Those are the three. And in foods, they are found in salmon, tuna, eggs, and other types of fish. eggs, dairy products, milk, cheese, and legumes, beans such as lentils and peas, dried peas. Thank you.
Jennifer Mwinzi saying, do we encourage the saturated fats or monounsaturated fats to give us cirrhosis?
Well, if you can take that one up, remember, as you're having your patients, there's another bit that you need to understand in terms of the biochemistry bit, in terms of how fats are metabolized. Because if you have to look at, there are several ways of how you can classify fats, depending with the length. That's why you have the short chain fatty acids, medium, and long chain fatty acids. So if you have to look at the profile of mostly when it comes to liver cirrhosis, you'd want to recommend MCTs, that is medium chain triglyceride kind of fats, because they try to spare the liver from metabolizing them. Therefore, because if you remember, you also require those fat-soluble vitamins, which can only be absorbed in the body in presence of fat. So therefore, you cannot say you're limiting fat per se for the patient, but now the choice of fat that you're going to give the patient also has to play in, taking into consideration other factors, not just simply by the mere fact that since it's fats, you just avoid giving to patients. So there are other factors that have to come into play whenever you're deciding on the type of fats you want to give to the patient. Thank you.
Thank you so much. From Anonymous, asking question about, can you give number of bottles or thoughts instead of grams, salt intake in terms of teaspoons? This is easier to communicate. I think, Christine, you can answer that.
As I had mentioned before, 2 grams of sodium translates to roughly about 5 grams of salt, 5 grams of salt per day. So 5 grams of salt is 1 level teaspoon, not heaped, 1 level teaspoon. And this should be in everything that the patient has in a day, not 1 teaspoon per item, 1 teaspoon spread throughout the day. And it is also very important that you counsel the patient on how to read food labels, avoid processed food so that they avoid the sources of hidden sodium and salt.
Eric Omboka saying, can someone has liver cirrhosis, DM, I assume that's diabetes. HTN with loss, how do you go about it, Sarah? I think that
Well, if you can try to answer the question there, remember from whatever position that we had, if the patient is on corticosteroids, remember it also gives you the aspect of hyperglycemia, which can at times lead to diabetes, which is whereby now I believe your question lies. And we have to also look at now what is the dose vis-a-vis the effect. And then you also have to take it wholesomely, since you're dealing with an individual, you're not just managing the condition, you're managing a human being. So you have to take into consideration all the other factors surrounding this particular patient, from the social support to what is the attitude of the patient towards the condition that they're having, so that we can be able to get effective solutions that are workable for that particular patient. So you can't have one silver bullet to kill this problem. So the problem is more of a multifaceted in a way, and you have to sit in with the patient, have a discussion, get him a better social support, and be able to take them through in terms of what is actually happening to them, so that now they can be able to appreciate and be able to implement the plan that you're coming up with. Because remember, this particular plan that you're coming up with, it's not that you're the one coming up with it. It is in conjunction with the patient, such that it's more or less you have to agree to disagree, whereby you're justifying why they need to change their dietary habits per se. How is it going to be helpful to them, so that now the level of adherence becomes higher, as opposed to when you're dictating what they need to be doing. So it has to be an understanding between the healthcare provider, in this case, the dietitian, together with the patient, so that now when the patient starts seeing the changes, they're able to appreciate where they are and where they're headed. Thank you.
To add on that, I think you need to see a nutritionist so that you can do an assessment, and you can make decision based on that assessment. Thank you, thank you.
Just hold on. There is Moham, just called. Okay, thank you so much, Mrs. Warento, for joining. She commends Christine. Congratulations, Christine, for mastering the nutrition language knowledge, and you are very eloquent. Thank you so much for that. In addition, we have a question from Mohammed Adan. He's asking, kindly, can we have, sorry, he's asking about examples of TPN in the same.
So parenteral nutrition basically is nutrition that is parallel to the enteral system, so parallel to the GIT. So this it can exist in several forms and is usually prescribed according to the needs of the patient. So parenteral nutrition may be in form of one, total parenteral nutrition, where this is now total parenteral nutrition usually goes through a central line and usually provides almost actually about 2,000 and above calories, which is enough for the patient for the day. Can exist this total parenteral nutrition can exist as a two-chamber bag, where the bag just has fat. In our case, especially with patients with liver disease, with metabolic dysfunction, and are not able to metabolize fats, they may get a bag that only is containing proteins and carbohydrates. There is a three-chamber bag that has proteins, carbohydrates, and fats. It also would exist as a single bottle formulations. These are formulations that have higher osmolarities and have to go through the central line. So in our case, osmolarity that is higher than 800 milliosmoles. For these ones now, maybe again, single bottle amino acids, single bottle fats, single bottle carbohydrates. For example, even dextrose in itself is a form of parenteral nutrition. And then when you're not doing parenteral nutrition, total parenteral nutrition, a patient may also be getting partial parenteral nutrition. Again, exists in all these other forms, as a three-chamber bag, as a two-chamber bag, and as single bottles. But then now, parenteral nutrition formulations that would go through the partial parenteral route, go through the peripheral lines, peripheral veins. Basically IV lines. So these particular ones would need to have a lower milliosmolarity. There is a lower osmolarity, a lower threshold. So these feeds can be now less than, again, 800 milliosmoles. So in our hospital, we usually have, in terms of amino acids, we have the 5%, the 7%, the 8%. Those ones would come with a lower osmolarity, 8% amino acids. Those are amino acids. The 10% that above amino acid formulations would go through a central line. In terms of fats, we also have formulations that would either go through a central line or would go through a peripheral line. So it really, the types of parenteral nutrition, one would depend on what is available to you in your facility, as well as what does the patient need. So if you have a patient who needs to restrict fat intake, then you would put it through fats. Also, again, you look at no fat formulation, sorry. You would also look at the duration that you would require to give the parenteral nutrition. If you estimate that you're giving for less than 7 days, then it is not prudent to be putting in a CPC, a central line to the patient. But if you're looking at the patient and you are forecasting that this patient may need parenteral nutrition support for more than those 7 days, then it is wiser to put in a central line and start early nutrition support. All right, thank you.
In addition to that, I'd like to mention that probably in the case of this today's presentation, we would consider using hepatic friendly formulations such as probably the 8%, which is commonly used for patients who have hepatic conditions. And in the form of fat emulsions, we would use the ones which have monounsaturated fatty acids as compared to the long-chain fatty acids. And then in terms of dextrose, there are different concentrations which can be used, either 10%, or you can reconstitute to other concentrations based on the requirements. It would be important for you to consider not going over and beyond, because if you give more carbohydrates, it will be converted back to fat, which will, if a patient was having fatty liver disease, it would propagate the fatty liver disease to become more rampant. Thank you. Thanks, James Kahika, for joining in. He's asking, in a case where a patient has liver cirrhosis as well as CKD, what dietary advice or restrictions are recommended? So most of the time we find patients who have hepatorenal syndrome, they will present with probably massive ascites, hypoalbuminemia, meaning low albumin levels, and bilateral pitting edema. In addition, they will also have deranged electrolytes, because definitely the renal, the kidney is not functioning well. So in such a situation, as we've heard from the presentation, we heard that some of the things will go hand in hand. So like for patients who have renal failure, you'll tend to have them having low sodium levels, but it will not be a very true picture, especially in patients who have bilateral pitting edema. It will be dilutional hyponatremia. So in this situation, it will not really be a concern, and you'll stick to the 2 grams of sodium per day. And then in addition to potassium, now you'll have to give the ranges of in renal patients. Now you'll have to ask yourself, is this patient on dialysis or not on dialysis? Is it a patient who's on who is a stable CKD patient, meaning they are not on dialysis, or they are probably on conservative management, or we are preparing for dialysis, or because there are different managements for either the ones who are on dialysis, those who are conservative management, and those who we actually preparing for what? Those who we are preparing for dialysis. So in such a situation, you'll have to check the UECs so that you're able to identify how much potassium you give. If a patient has hyperkalemia, definitely you'd want to give a potassium restricted diet. If a patient presents with hepatorenal syndrome and they have hypokalemia, in such a situation, however much they are on dialysis or on conservative management, you'll have to adjust your potassium requirements based on the current biochemical parameters. In addition, in terms of the caloric requirement, it would be the same for a patient who is on dialysis and for a patient who has either end-stage liver disease. we were told initially in the presentation that they should be on 35 to 40 kilocalories per kg per day, which is also applicable for patients who are on dialysis with renal failure, as a result of renal failure. But for those who are on conservative management, the requirement is at 30 kilocalories per kg per day. So it depends with how the patient is actually presenting. Another factor to consider is for patients who have fluid restrictions. We know that patients who have chronic liver disease or those who have end-stage liver disease, most of them present with massive ascites. In such a situation, you would want to go down on the fluid because they do not have adequate urine output, or whatever they consume versus whatever the output is not the normal urine output per day of 0.5 to 1 ml per kg per hour. Right, so you would want to go down based on the output, because even in renal patients, you'll find them having reduced urine output. So in such a situation, for a patient who has hepatorenal syndrome, you will work with the actual urine output so that you determine how much they're supposed to take per day. Thank you.
Thank you so much. What Sarah is actually advocating is we need to individualize the case. Every patient needs to be individualized in terms of management. Then identify what's the other thing that this patient presenting with. Is it the albumin? Is it the renal insufficiency? Then we work as a multidisciplinary team. We also check on fluids therapy that doctors and other healthcare team are managing the patient. So thank you so much, Sarah, for this, for that elaborative Christine, we thank you for today's very elaborative presentation, and for our guests which are attendees, we also appreciate you for your time, for your bundles, and below the presentation is the references where all this information were obtained from. Thank you so much, Christine, Sarah, Agri, and Kemboi.
Well, just as a parting shot, this is more of a summary of the essence of the presentation. If you look at the title, it was all about medical nutrition therapy. So the key point here is you're using nutrition as a therapy, not just as a means of getting nutrients to the patient. So there has to be a goal at the end of the day, which has to be been agreed prior to you implementing your plan. So let's just remember, in terms of, in as much as it is patient management, it has to be therapeutic. So there has to be goals at the end of the day, and there has to be an implementation plan which is agreed upon between the HCP and the patient. Thank you very much for attending, and see you next time.